I appreciate everyone's patience and stamina and staying to the very end. So thank you very much for coming to the course. I know it's very inconvenient on a Saturday. It's a commitment, and very much appreciate it. I also want to thank our course directors, Sean and James. They've done an amazing job putting together a great program. I want to thank all the speakers that have taken time out of their schedules as well to come visit. We've had some very distinguished speakers speak today. I know some of you may be new to this area, but the speakers that came are actually very well known in their field, and I want to thank them as well. I want to thank also the support staff as well for coming today. So I want to have a little fun with this talk and pivot a little bit and just approach things just slightly differently. I've kind of gathered notes during the day, but let me give you a little bit of background on my perspective. So my perspective comes from really getting input from multiple areas of the country performing cardiac CT and preventive cardiology. So we have offices throughout Arizona, but we have Florida, that's our connection, one of our connections with Southwest, but in multiple parts of the country. So I get feedback in different areas. We also are one of the largest providers of outpatient cardiac CT in the US, and we know that has been validated talking to third parties. So we have a lot of experience. But our perspective, and my perspective, is a little different. I'm going to simplify some things. I like to be a little controversial sometimes, so please take it with a little bit of thought. And if you disagree slightly, I understand that. But we're really at an amazing time in medicine, and in particular, when you look at heart disease, coronary artery disease. It is truly amazing. We have hundreds of thousands of patients a year dying of heart disease, and we can save them. Everyone in this room has the opportunity to save many lives, whether they're a physician or a provider, or even helping support the presentation today. The information that you gain can save lives. So it's an amazing time in a couple different ways. One is we have new diagnostic tools. And I'm going to go through and just reiterate to make sure we're clear on the diagnostic tools. And we have new medications to treat coronary artery disease. I've heard quotes today, 9 pathways, 12 pathways. I've been saying 15 pathways. There's more pathways than anyone in this room probably can follow without an algorithm or a card to help them. But there is more than one way to treat coronary artery disease: to prevent it, and if you have it, to stop it, and potentially to get it to regress. And one thing I want to remind everyone is coronary artery disease is part of a broader process, atherosclerotic disease or inflammation. It generally, unfortunately for most people, affects multiple areas of the body. My background when I started in practicing was interventional radiology. Did a lot of procedures, vascular procedures. It's ugly. When you get atherosclerotic disease, you not only have concerns of shedding plaque, causing emboli, but you'll lose compliance in the vessels. Your whole physiology changes. So when we talk about coronary artery disease, I'd ask everyone to step back and think of it in the broader spectrum of atherosclerotic disease and every vessel in your body. And to highlight coronary disease is critical, but there are other areas, in particular stroke. Every person in this room, everyone I ever talked to, when you talk about, ways not wanting to die, having a stroke is not at the top of the list. You do not want to have a stroke, right? So you're talking about atherosclerotic disease in the coronary arteries. We're talking about these treatments, but these treatments will impact other blood vessels, including stroke. We didn't talk about this today. Small vessel disease, dementia. What can we do to prevent dementia related to vascular disease? And it's thought currently, and the knowledge changes, about half of the cases could relate to vascular disease. So again, coronary disease, at least when I think stroke, think dementia, think other areas of the body. So every decision you make with your patients relating to coronary artery disease has a much bigger impact. And you may be the only provider that is addressing those issues. So that's unfortunately the burden that you have as an expert in this area. So I want to go back to CT real quick so it doesn't become too intimidating. If everyone here's had a chest x-ray, probably. You have an x-ray tube and a detector. You put it on a round ring, detector, tube, rotate, you have a CT scanner. Not complicated. circle of metal, and mount it, and it rotates around. So what's interesting is one of the first outpatient cardiac centers actually was founded in Arizona, because I founded it, so I'm familiar with it. That was about 24 years ago. Opened with a cardiac CT, cardiac MRI. When I opened it, people said, why would you want to do that? Why are you spending extra money on cardiac CT, MR? Why? Why is to understand the technology and to be able to provide it. So what's interesting is we've been able to provide coronary CT angiograms over 20 years. 24 years ago, we did CT angiograms. So what's different now? We're here today. I just said it's crossroads in technology. So what has changed? So let's talk about the technology, hardware, CT. What's changed? Incremental improvements. Use your cell phone. It's a very simple example. Incremental improvements. The hardware itself got better. The X-ray tube rotates faster. The detector is more sensitive. What does that mean? You can capture cardiac motion better, so you don't have blurred images. The detector is better, so you have a lower radiation dose. There's parts of the world you can go to today, and they don't do chest X-ray. They do CT of the chest. They recognize the dose of a chest CT now is similar in many cases to a chest X-ray, but you have a lot more information. So when we approach a CT today of the coronary arteries, we view it as a plane trip. Simple as that. So we're not afraid of radiation dose. Radiation you have to be very cognizant of whenever you're using ionizing radiation. But what I'm saying is you have to put it in perspective. And the perspective today, some parts of the world aren't even doing chest X-rays. They just do CT routinely. What we're talking about today is coronary CTA. The dose is very low. Then let's talk about the second element, which is really the hidden element in this room, cost. We're an outpatient provider. We were founded on providing affordable care. We're not the only one, but a typical reimbursement for a chest CT angiogram, coronary CT angiogram is between $250 and $400. That's it, $250 to $400, not thousands, $250 to $400. Every market we're in, from New York to California, and there's other providers. How does that compare? Mammogram is about $200, for example. I know many of the medications we talked about, one dose or more than that. So in terms of cost, $250 to $400, half of our patients, Medicare, Medicaid, it's covered. The other half may or may not have a deductible, but $250 to $400. How does that compare again? Often the same price of an echo. Most often less expensive than a nuclear medicine study. Much less expensive than a PET CT. So you have a study today that is extremely safe and is of a relatively low cost. The third component, which has changed over the years, is reproducibility. You can send a patient today to a cardiac center and get a study done that literally takes seconds, not exaggerating, seconds to complete. Now, 24 years ago, first sight, it would have taken a little longer. The scanner was a little slower. Everything had to just be perfect. Today, you have more room to make error. But the fact is, in seconds, it's like a Star Trek episode. I'm not exaggerating. Within seconds, at a reasonable cost, you can have a safe exam that will tell you what's going on with the coronary arteries. You don't need any indirect study. You can see it. So that's really the status of where we are today. The question is that enough to make it even popular? Would we even be talking about it today? I don't think so. So from a practical perspective, over really the last few years, we could have produced a report describing plaque, describing stenosis at a reasonable cost, and it still wouldn't have been widely adopted. So the question is why? One of the reasons is communication. How do we communicate the results? And I understand it's very important how you communicate as a radiologist to providers, but as an interventional radiologist also to patients in a way that's understandable. And I have to say, probably most of the images I've seen today where the coronary arteries and people will point to the plaque, you can't see the plaque very easily at all. The plaque is dark. The vessel, you'll see these elongation of the vessels, and people are going quickly talking about plaque. I've 30 years experience. I can't see that instantaneously. So you're not missing anything. It's actually very hard to see and explain in a three-dimensional structure. So for the last few years, we've been able to produce reports. We could describe the stenosis. We could give you an estimate of the plaque, But if you were looking at it as a provider, it'd be really hard to see. And to try to show that to a patient, it's nearly impossible. So we've had improvements in the diagnostic technology, and then what we have now is AI. And AI has made it easy to understand and present. So what the AI is able to do is take that data, again, it's been available for the last few years, and convert it into a form that's visually understandable. It'll take a coronary artery that curves this way and that way, straighten it out, and for all that little plaque along the border or margin that you visually can't see, most people can't see it, it turns it into a color-coded mock-up. And so you can show to a patient, see the red, that's your bad plaque. You know, the yellow, that's your calcified plaque. And here's the total number, and this is how you compare to other people. So I can see it, and I can know how I compare. Third element, we talk about FFR, which I think is a very confusing concept to try to explain. So I'm going to give you my simplified explanation. I apologize to the experts that have come in today. But I view it in a way as an interventional radiologist, but in a way I think everyone would understand. So atherosclerotic disease, in most cases, isn't a solitary stenosis. If I'm an interventionalist and I see an 80% stenosis or a 60% patient has symptoms, you're going to stent it. There's like zero chance you're not going to intervene, right? But that's not how atherosclerotic disease usually presents. It's diffuse disease. So what do you do? Everyone here can be an interventionalist. I'll give you the problem. A patient with symptoms, I have a vessel, diffuse atherosclerotic disease. 40% narrowing for 1 centimeter, then it gets a little better, then 50%, then 30%. It's a lot more complicated, right? Where do you intervene? Do you use a long stent, short stent? How much are you going to dilate? What if I could tell you what the pressure is along that whole vessel in advance so you could plan out how you would approach it to look at that sum of the total of disease? And again, I'm simplifying and twisting a little bit, but if you're going to explain it, it makes sense. I want to know the total impact of that plaque on the flow in that vessel, and we can do that through artificial intelligence. It's amazing it works, but it does because it's been correlated with real studies. So I'm able to give a report to a provider or a patient that will say, see this color-coded, this is good, this is bad, and this is how you compare to others, and that's why we want to treat you. I can tell them this is an inflammatory process that's throughout your body, most likely. This is just one window into it, and we want to treat your heart because we don't want you to die a heart attack, but we want to treat you because we don't want you to have a stroke, we don't want you to have leg pain, we don't want you to have hypertension because of the arteries to your kidneys. This is our window in. It's a very accurate window in. The good news is that we can treat it. That's not 20 years ago. This is now. We can treat it, and I can even do a follow-up study to show you you're getting better. So this is controllable, treatable, objective, quantifiable. No mystery. I want to talk about just a couple other practical matters. We talked about the CT, we talked about the reporting. I didn't talk to you about the connection between the two. So the AI technology, let me just step back for a minute. We're very aggressive in adopting technology. We have a unified platform nationwide. So on a lot of our AI products, we're on 3rd generation. There's groups that are trying their 1st generation. We're already on 3rd generation products. We're always constantly testing. If there's a better product, we'll train and switch. So how the connection is, you have to get the images from the CT. Like I said, we've had for the last few years great images, the images. You have to get them to the processing. The 1st generation products, you send them to the internet, and you get a report 2 days later. They would process it. Someone had asked, can I take an old image data set? The thing is, you just have to require high-quality images. If you acquire high-quality images, then they can be processed. That's what wasn't said. You don't want to go to a center that doesn't know how to do it. Centers that work with the processing companies know how to produce high-quality images. They were producing it before. That's what you just have to make sure. What's changing with the AI is the reports are getting better, and also the processing time now is instantaneous. The newest products are instantaneous. It doesn't go anywhere. Boom, you do the CT, and within seconds you have everything you need. The practical issue, which is important for everyone to understand, is there's artificial roadblocks. So I know there was a question asked in the other room about calcium scoring and age cutoffs, which in fact, you can get a calcium scoring from anyone. And they were talking about an artificial cutoff. There's all kinds of artificial things that have come up because of the insurance plans. So what we're dealing with on flow makes sense. I have diffuse disease. I want to know what's the total impact of that disease in the blood flow in the vessel. Very clear. The latest we have from the insurance plans is that they want us to wait. You do the CT first, and then we'll decide if you meet one of, it's not one criteria, by the way, it's multiple criteria. Then we'll decide whether we'll pay for it. So what we do either is send the images, or if it's instantaneous, it really doesn't matter. It's done, but we can't issue the report or bill for it until we know we get paid. So the constraints of delays will go away completely as all the vendors catch up. So you'll have the data instantaneously. The question is, will the vendor let you release it unless they know they're going to get paid, or you'll just take the risk? I mean, last week, we processed some images for a relatively famous hospital system. Someone called and said they have a standoff, they won't work with this vendor. We took the data, because it's high quality, and we processed them to state the cost and provided it, but it was instantaneous. So delays that you're hearing about, some of it's still the AI generation, but the newest generation, again, all the data is instantaneous, which is great. So the question is, and I was thinking about this during the course of the meeting, and there's different folks from private practice and academics. And again, I will be controversial. I think the pace of innovation is incredibly rapid. It's just amazing how quickly it's going to occur. And if we wait for the insurance plans to come forward and pay for it, you're going to be waiting years. So it's up to you to decide if you want to have the patient at least have the option, if they want to pay for it themselves. Because in some cases, that's the way it's going to be. And we have all kinds of examples, and I know there's different fields in medicine here, but in radiology, we're faced with that now. In almost every area in radiology, we can add AI and improve the diagnosis. And in almost every area, there's no interest from the payers to pay it at all. Our approach is to try to get things at a reasonable cost, and that's one area that when you look at the cost of the CTA at $250 to $400, the software still is very expensive, and we're hoping that price will significantly reduce. This is comparison for everyone, because it may seem glib for me to talk about AI and how easy and patients paying for it. When I talk about it in radiology, we think of AI as $1 a case to $50 a case, not $1,000 a case. So it's a totally different scale when we look at AI and what we're doing. And we see products in radiology that are very complicated. And so we're hoping that some of the coronary-specific products will decrease in time. So just to finish up, there's two things I wanted to stress. One is systemic disease. Please don't forget that. And where will that take us in terms of the future? I believe, and again, this is based on just my experience and talking to we have a lot of specialty providers in cardiovascular imaging, is CT so quick now. If you're imaging the heart, you can image the carotids and the intracranial blood vessels. If you think about stroke, think about dementia, you think about a study that takes seconds, minimal radiation dose, again, like a plane flight. Why wouldn't you look at the heart and coronary, carotids and intracranial? And it would not surprise me that if we're 2 years from now and we're talking about, do you just do the heart or do you do multiple vessels while you're doing it? And we're involved with a trial now to validate it, but I really, frankly, think that's the direction it's going to be. Again, you're talking seconds. The other thing which is really important to understand is longitudinal with CT. And you had a lot of technical explanations, but no one really kind of addressed it head on. So the issue is, I already said visually, it's really hard to see on the black and white images, and try to measure in all this. We heard from Amir talking about, he believes like focal lesions are more important than diffuse plaque burden. But how are you going to do longitudinal studies and compare all these little fine details? Visually, you can't really see it. Color-coded, it's a mess. I mean, it's just, you have all these different things. You're going to need AI to actually provide you the quantification, to know total plaque burden but also the types of plaque, and has it changed in 2 years? And maybe if you follow what Amir was saying, maybe it's that one plaque that they think is a higher risk plaque. Did that change specifically? So you're talking structures sub-millimeter on vessels that are many centimeters. So longitudinal care is very important, and it's something to think about. So when you do a coronary CTA, when I think about it, I think about this as a study that you're going to do as a baseline, hopefully in a young person, before they get disease. And then you'll do it longitudinally, not only to prevent death, but I didn't hear this today, health span. You want to live longer, but you want to live a healthy life. You don't want to live with a reduced ejection fraction because you had a heart attack but survived. You don't want to have a stroke and live another 10, you may want to, but it's not a great health span, right? Dementia, if we can avoid that. So I really would ask you to consider and to be aggressive with CCTA in that it's something that you can understand. You can see it, patient can see it, you can understand where patients are, where they are. Compliance is a critical issue. I understand that. You can get great compliance if you can show it to them, and you can promise them, look, you may be reluctant. I can show you we can stop this process, and we'll come back in a couple years, and I can do a follow-up if we need to show that we've done that and complete the circle. But anyway, I'll let everyone go. Enjoy a little time outside today, and wish you all safe travels back to your homes. Thank you all.